Hi. Hello and welcome to Knock Knock Hi. We are the Glaucomfleckens. I am Dr. Glaucomflecken.
I am Lady Glaucomflecken.
And we're happy you're here because we have a wonderful show lined up for you today.
A lot of people have been asking for this guest.
Yeah, Dr. Mike. I don't know. You may not have heard of him. He's kind of an emerging voice in medicine. No, he's everywhere. I mean, he does some incredible work. Love watching his videos and the education aspect of it in particular. He does such a good job with as a family physician. But before we get to Dr. Mike, it is February.
It is February.
And what is February?
February is American Heart Month.
It's other things.
It's other
things.
It's
got Valentine's Day.
Sure.
Sometimes it's got a leap. Is this a leap year?
What year is it?
I don't know why I asked you as if you like keep track of leap years.
No. Last year would have been the leap year.
How do you know that?
Did you know that leap years... Wait, is that right? No, next year is the leap year. Leap years are the same year as presidential elections.
There you go. That's how you can remember it. All right, that's a good mnemonic device.
I think that's true. Don't quote me, but I'm pretty sure.
But most importantly, it is World Heart Month.
Nope, American Heart Month.
Oh, American Heart Month. The world doesn't care.
The world celebrates in October, but February is American Heart Month.
American Heart Month. And hearts are a big part of our story. We've talked a little bit about our cardiac arrest before. Our cardiac arrest.
Well,
it kind of was. In some ways, it was the two of us. Mine was the only one that short-circuited. And so it's... And CPR is something we've talked about a lot. One thing that, I was a physician for about 7 years before I had a cardiac arrest.
Mm-hmm.
And not one time in those 7 years in which I was like thinking about medicine, working in medicine, learning about medicine, at no point did I think, hey, maybe my wife, who is not in medicine, should learn CPR.
Yeah, we just sort of assume if there's some sort of medical situation, well, that's your territory.
Yeah.
And if there's like homework help or emotional help or literally any other kind of help, that would be my territory. But medical stuff, we thought you had covered.
It didn't work out that way.
No.
And so it's something that everybody should learn. It should be taught in schools. It should on workplaces, everywhere, because the effect that chest compressions can have on saving your life is incredible.
It's huge.
Out of hospital cardiac arrest, 1 in 10 survive. 1 in 10. And if that person receives appropriate chest compressions and effective chest compressions, their survival goes up to about 3.5 out of 10.
Well, and depending on how you slice it, it can go even higher than that.
The point is, though, that is a remarkable improvement with something that is relatively simple.
Yeah.
That everyone, if you're physically able to do it, you can do it. And so it's there's very few things in medicine that are like that, to be honest, that have that effect on survival. And so that's why it's just so important.
It's very important. And I would also add, I think there's a lot of people who are afraid of doing chest compressions because they're afraid of hurting the person. But the person is already dead.
Yeah.
So you can't hurt them more.
That's right.
You're just giving them a chance at life, and better to have some bruised ribs or even broken ribs and have a chance at life.
Somehow you did it without breaking any of my ribs.
Either
I have ribs of steel, or you're just so good at chest compression. You're able to do it just effectively enough to where you saved me, but not broke any of my ribs.
Well, you're young and healthy. I think that helps.
That's a big part of it. Yeah, you get a little bit more brittle as you get older, but well, that makes me feel young. Thank you.
Oh, you're welcome.
I like that.
But even if you don't, even if there's not a good outcome when you gave CPR, just to try to give that person a chance, you've done a good job. That's all you can do. And, I think a lot of the times we talk about CPR as a way to save someone, and it certainly is, and that's very important. But it's also important to recognize the people who attempt to save someone, and it just wasn't in the cards for that person. So it's always good. Just to try.
Yeah.
Give them every chance they can have.
So we'll be talking a little bit about chest compressions and things with Dr. Mike, because he's done some advocacy work surrounding that, and we just had a great conversation with him. So we're excited about this one. We hope you like it.
Yeah, he's got a really interesting story.
He does. Very interesting story. We talked a little bit about social media and just kind
Yeah.
of a
Uh,
wide-ranging conversation. So should we get into it and
let's
stop
do
just
it.
talking between ourselves and actually like let people
Let's go
hear?
talk to Dr. Mike.
All right. We'll be right back. Dr. Mike, thank you so much for taking the time to join us.
I'm so
It's
excited, and it's awesome to
yeah,
meet you for the first time, despite our trajectories being quite similar in the social media world.
right? It's like I feel like I see you all over the place. You probably see me from time to time as well. And it's actually I got to make it onto a Dr. Mike video one time, and which was very exciting. And I got one of the shirts you're wearing right now, the chest compression shirt, in the shape of a heart. Great design, by the way. I love that thing.
Shout
Yeah,
out
I want it in a
Caroline.
lady style.
Yeah,
Yeah.
yeah, we
Yeah.
We
could
have
get you
it.
one
I will
for
get you
sure.
one.
Absolutely. I mean, I have one.
But not in a lady
I
style.
sleep in it
Yours
every
is too big
night.
for me.
It's wonderful.
Is that like
And
for educational purposes to make sure that if anything happens, people
Just
know to do chest
here's where
compressions?
you do. Well, I've done it once, so I think I could do it again.
What an
yeah,
incredible
yeah.
story.
It's
Yeah.
pretty wild. And this is this episode will be coming out during
American Heart
American
Month.
Heart Month. And so yeah, it's you are, much better at it than I am. She's had more practice at this point than me as an ophthalmologist at
Probably
doing chest
true.
compressions. But I wanted to ask you, what was the impetus for moving in that way, doing some advocacy toward, CPR? And because I really appreciated seeing that from you, and I think it makes a big difference having physicians in particular, obviously, talking about this who have large social media platforms.
For sure. For me, my venture into social media land happened without a big plan behind it. So once it occurred, I wanted to do something meaningful with it. And
Mm.
that constantly shifted depending on where I was, either in my training or coming out of my training, becoming an attending, how big my following was. And specifically, this advocacy around chest compressions came about because I would watch the medical dramas, react to them on my YouTube channel, and constantly I would see them not do chest compressions or do them terribly, reach for the defibrillator during asystole, and I would lose my mind yelling at the screen, and it became the mantra for the channel. And
Right.
somehow it now has transitioned into working with the American Heart Association and getting these CPR kiosks all across the US to getting people to learn how to do proper CPR.
But also, have you managed to make a change in Hollywood? Has it? Do you
No,
feel like you're having an impact there
no,
in terms of the
absolutely not.
quality of the?
This is a fun fact. I was very close to being on the show Good Doctor, but because of the second wave of the pandemic, they had to
Ah,
call off shooting, and it was like 2 weeks quarantine that you would have to fly up to Vancouver and do it. So I missed out on that opportunity. But I would have been in the back yelling chest compressions, even if it didn't make sense in the scene.
it just telling you how to do it appropriately to 2 inches deep. Come
Yes,
on,
exactly.
faster, slower. It's really all over the place with that. And you talked about our kind of divergent our paths kind of on social, because I'm the same way. Like, I didn't set out to generate this following. In fact, for me, doing the videos and stuff was just, we were locked down in the
Mhm.
pandemic, and I didn't really have anything else to do. We had to close down our clinics and everything, and started making videos. But you and I, we actually, I think we graduated residency the same year. You're 2017, is that right?
Yes. Yeah.
All right.
Mhm.
And
I love it.
so you are practicing, a practicing
Uh,
physician. What is
yes.
your clinic schedule like? I've been dying
I
to know.
Yeah, I work 2 to 3 days a week, depending on the week, and, one of those days is usually a precepting day where I'm
Hmm.
watching over residents, teaching procedures, whatever it may be that
Nice.
given day, and then the other day, I'm taking care of the patients that I sort of picked up throughout my residency training, and then also seeing patients that are overflow that would like to see their physicians that are in our
Right.
practice, but they don't have appointments available and they have an urgent need, so I come in and fill that need.
And was it for you in med school, were you family medicine the whole way? or did you kind of,
Well, med
go
school,
between different things?
I guess it depends where in med school we're talking about. In the first 2 years, I was really interested in surgery and thought that was the field for me. I was good with my hands. I was a big gamer. I saw the future
Hmm.
of the Da Vinci robot being in my future. And as I went into my third year, where you would do your clerkships in surgery, and I scrubbed into like 60 procedures, I realized it wasn't for me. And I didn't enjoy it as much as I thought I would. So, a lot of the times, the things that we envision to happen in certain specialties don't actually pan out, which is why when I speak with med students, I'm like, please go and work with a doctor during one of their shifts just to see what they do so that you don't have a misconception of what their day to day is like. Because medical
That's
dramas are
true.
also responsible for
Yeah.
that misinformation.
That's right. And also in working with actual, doctors practicing in those specialties is seeing the mundane parts of their job. Like what are the things they're dealing with day in and day out that may not be as exciting, but you can still stomach it and,
Exactly.
be okay with doing that. So really what I'm trying to get at though is why on earth did you not choose ophthalmology as a career?
Honestly, I wasn't smart enough for it.
Oh, come on now. Did you
Yeah,
did you ever get to do an ophthalmology rotation? Did
no.
you?
In
No.
fact,
Okay.
I openly say, I think I have a video coming out this week. My two biggest weaknesses of the human body are the teeth. Like if a patient comes in and says, I
That's
have something wrong in
everyone.
my mouth, I have no idea what to do. And then the second is the eyeball.
So I'm sure that you've had so many experiences. You're in an interesting field, taking care of every single part of the human body, which sounds terrifying to me as someone who specializes in something that's 2.5 centimeters long. And so I'm sure you have some stories for us. Have,
There's a lot of stories. I mean, there's a lot of things that go wrong. And as you said, it's a field where every day it's humbling how much you don't know.
mhm.
And because of the use of resources online, because of ChatGPT, dare I say, now my job has become more about helping patients make decisions, helping them understand medical concepts, guiding them through a terribly broken system, rather than being an expert in a given body, organ,
Mhm.
system, what have you. Because everything that I do, as long as I can be a good decision maker, I can get the information and knowledge from good quality resources and then adapt it to my patient. And I can't tell you how often it is that I see a patient and something triggers in my mind about a condition that I think it could be. I have to look it up and I do it right then and there with the patient in the room. And we almost match up the symptoms and what they're experiencing together in order for them to understand why I'm thinking it's more this than something else. Creating that list of differentials, creating a plan of why, if this workup doesn't work out, here's the direction I want to go. And it's really become a fun field in my eyes because it's almost like you're playing detective in addition to being a doctor.
Yeah, and it's that's something I think a lot of trainees are nervous about moving into the attending part of their career is what if I'm expected to know the answer? What do I do? And spoiler alert, there's going to be so many times whenever you are in that first maybe even now I'm 5 6 years out of training, but especially in that first couple of years where you don't know. You're like, well, I think it's this. I think I remember what the medication is for this condition or what the dose is. I just have no idea. And what you don't realize is patients really appreciate you taking the time either in the room there or outside the room just to figure out the right answer. They want the right answer.
And
That's what they want.
from the non-medical perspective, I think that's crucially important what you're doing, because we're moving away from this idea that doctors are just this fountain of knowledge, right? And that's the value that they bring to the interaction. Well, now there's knowledge everywhere, and there's too much knowledge, and not all of it is correct. And so now I feel like, the 21st century doctor is going to be somebody who is skilled at doing just what you said, of helping people think critically about the information, understand what's good, what's bad, how things relate to each other, and how that all relates to your specific case as a patient, and helping them go through that thought process rather than just, oh, I have all of this memorized, so just do whatever I tell you.
And the sad part is medical school does the exact opposite in
Yes.
educating you. to set you up for almost failure when you walk into that exam room. You're like, okay, I can
Right.
tell you everything you need to know about the Krebs cycle, but I can't help you figure out how to get cheaper medications for yourself.
Or I can't
Right.
help you with your teeth. It's,
Yes.
it's not going to happen.
Teeth and
I'm so
eyeball, man. Like
sorry.
it wasn't taught enough. And
Oh, it's
my
okay. For me,
ophthalmology
it's
professors are going to be mad, but
For me, it's below the nasal bridge. So I think you
okay.
cover a lot more, anatomic parts of the body than
Oh,
I do.
I
So,
actually had a bad situation happen with my eye where, so, doctors always ask each other to prescribe antibiotics, allergy meds, whatever,
mhm.
like minor stuff. And I had a preseptal cellulitis going on.
Oh
So I
no.
looked
You
up
had
to
a what
date
now?
Preseptal cellulite.
I would leave it to the expert to
Y-
explain.
Yeah, so it's an infection of so the septum, the orbital septum is a very important part of the structure of the eye.
Okay.
It separates the back of the eye, so the space behind the eye,
Uh-huh.
from the space in front of the eye.
Okay.
And so a preseptal cellulitis is an infection basically of
I'm
the
falling asleep, so I'm kind of sorry
this is
I
very
asked.
exciting. The preseptal cellulitis is an infection in front of the septum.
Okay.
Basically, it's like not quite as bad orbital. So
Uh-huh.
an infection behind the eye
Sure.
is really bad.
It's hard to get back there.
Yeah, it's hard to get back there. And so the septum, that's why the septum is very important. So if it's an infection in front of the septum, it's still a big deal, but it's easier to treat, not
Okay.
as like potentially, deadly.
Right.
Yeah. So
That's
So
I
you had a
disgusting.
preseptal cellulitis. That's
I had
man,
that.
people are learning. I'm glad people are learning about this
Yeah.
today. That's good. All right.
It's a good eye condition. And this is to show you why doctors are bad bad patients themselves.
hmm
What did I do? I looked at antibiotic spectrum, what I should use for preseptal cellulitis, and it was double coverage of antibiotic A and B, and one of them happened to be, I think, augmentin or amoxicillin on its own. And I asked my friend, I did residency with him. I said, "Hey, can you prescribe this? I have preseptal cellulitis." He's like, "Sure, no problem." He sends it through. I take it. 2 days later, I'm in a huge rash. And I'm wondering, like, where did I get this rash? I'm going through all the differentials, and I completely forgot I'm allergic to penicillin.
Oh no.
Like, how do I give myself the medicine that I'm allergic to? Like, you would
Oh
think I
my
would be a better
goodness.
doctor. Meanwhile, for my
Oh
patients,
man, I love it.
anytime I'm about to prescribe something, it's two
Yeah, it's the
questions. Do you have
first
any
thing you
allergies?
ask.
What pharmacy do you use?
Right.
But for
Right.
myself, never asking that question.
We are the worst patient. Did it get better? At
It did
least
get
did
better. Yeah.
you got into something different? I'm guessing.
Yeah. Yeah.
I'm glad you
Actually,
recognized it.
I think I'm misstating the number of days because I have a rare delayed hypersensitivity to the penicillin. Back in the day, I had mono, and my dad gave me amoxicillin. I broke out in the rash, and ever since then, I have this delayed immune hypersensitivity that, like 4 or 5
Really?
days after starting penicillin, I start breaking out in a small rash, and it progressively gets worse, even though I'm off of it already.
Ugh.
Well, I would say that you probably won't make that mistake again, but who knows? I don't know. But I'm with you when it comes to being a bad patient. I, have to be reminded to take my medication.
Oh yeah.
And
His response to everything is, "It's fine."
well, it's you get this skewed view of the world. I think a
Right.
little
If
bit
you're not dying, then it's fine.
as a physician because it's the minor things seem very minor, but to people who are not in medicine, the minor things can be a big deal, right?
Of course.
Or at least you just don't know. And so, yeah, whenever like my kid's like, "Oh, I have a stomach ache," I'm like, "Hey, you're fine. It's okay.
So compassionate.
Shake it off."
Such compassionate care.
I would not advocate that as a way to be a parent. It's not the
Yeah.
best thing, but
That's what
I
I'm here
think
for.
it's my curse as a physician and having seen a lot of, crazy stuff
Right.
out there.
Right. Your barometer's a little skewed.
I guess so.
Well, you guys have a good balanced approach to it. I'm curious, are either of your parents doctors who did that to you as well? Because my dad definitely did that to me being a USSR doctor.
Yeah, no, neither of our parents are in medicine, so I
No.
was the
My
first one in my
grandfather
family.
was a physician, but
Oh,
he
that's
was
right, yeah.
he's a grandpa, so he's a lot more,
Yeah, we're talking very old schools, like 60s.
Yeah, but he was he invented the Mighty Vac, the vacuum extractor that people use in labor and delivery. So
Wow.
I don't know. I feel like he had a good, compassionate approach to us
Yeah.
when something would happen.
But yeah, I know your dad was a physician in the
In
USSR, you
Russia.
said?
Yeah, in
Yeah,
Russia. And
that
then
must have
also,
made for an interesting upbringing.
Yeah, big time. Because he not only was a doctor there, but when we immigrated to the United States, he went to medical school and residency all over again. And I was
Oh,
now
wow.
10 years old, so I got to watch the whole journey. Most kids are young when their parents are going through that. And it firmly placed rules that I'm not allowed to do poorly in medical school with an excuse because he said, "Hey, I did it twice in a new language, so
Right.
you can't say a test was
Yeah,
hard."
no, that's right. You could. It doesn't matter how many quizzes on the Krebs cycle you have to take. You're going to pass them,
Yeah,
Exactly.
and
and
you
you're
got a
going to.
cheat sheet. You already got to see it once. So
That
Well,
is
I don't know how much I was paying attention to the Krebs cycle at age 9, but
having gone through med school and residency. I honestly can't imagine like doing it over again. That is
Ugh,
so impressive.
yeah.
A different language. I
yeah,
mean
that's a question
that
I have for you.
that.
What would it take for
Yeah.
something to go wrong in this country that you would leave, go learn a new language with $0 and do residency all over again at medical school? What would it
Well,
take? What would
a
have to go wrong
divorce
here?
for one.
Yeah, we'd have to. Yeah, that's true.
I'm not doing
I
that
don't think
again.
my family would be up for it. So that's the first thing.
Okay.
I'd have to be guaranteed a position in ophthalmology because I feel like at least, it's, I guess depends on the language, but if it's there's a lot of Latin background, right? For a lot of what we do. And so
Yeah.
depending on the language, it might be like accessible, but still extremely difficult. I don't think I could do it. I don't know. I don't know what it would take. But what were the conditions I have to ask for your dad to make that decision?
Yeah, I was so young that I didn't really have any say or knowledge about what was going on in the moment. Now, when I would ask, he would point to the current geopolitical situation going on
Mhm.
in Russia and the terrible atrocities that are happening in Ukraine. Because my father was actually born in the Ukraine and then moved to Russia for his studies. At that time, it was USSR, so it was all one country.
Yeah.
And he would say the corruption is terrible. There was anti-Semitism he was concerned about. He didn't think my sister and I had a future there, so he essentially came here for us and went through that whole journey. And I can't imagine what it would be like for me to do that in another country right now.
Yeah. That is the answer, that's what it would take is if your children's lives were going
That's
to
true.
be,
Mhm.
you know, very negatively affected. I think parents would do just about anything.
And it's just really impressive that to make that leap with a family, and I'm guessing you got a lot of. Did you get any experience? How old were you actually whenever you came over
6.
you're 6? Do you have any recollection of being in hospitals, going to work, and seeing that environment? Is that because you were pretty
Not
young
in
then?
Russia.
Not in Russia.
In the States, there were days like in residency, you would bring your child to work day and I
Yeah,
would come
I
along.
was gonna ask. Yeah.
Yeah, like
In
my dad did his
residency.
residency in a hospital that no longer exists. And when I went there, I remember going to the on-call rooms and being like, "This is so cool. It's like sleepaway camp." Meanwhile, I was like, "This is not sleepaway camp."
This is it's like a prison cell
Yeah.
of a call room, right? And
Well, it
I
goes to
can't.
show it's beauty is in the eye of the beholder. I was a kid that looking at bunk beds and seeing how exciting it is. Meanwhile,
That's
he's
true.
45 years old living in a bunk bed. So
Right.
Yeah. I honestly, it's a I can't think of many things that would make residency more difficult, but bringing your child with you to work is probably going to be high up on that list. My God.
yeah, I don't
Because
Oh, I
know.
I'm
can't
sure you were
imagine.
very well behaved at all times and didn't, cause any,
Kept your
commotion
I
or
think
hands to
I
anything
think I was
yourself,
only
didn't ask any
invited for an hour or
questions.
two before they had to get rid of me.
when it was when it was necessary. And what kind of medicine did your dad practice?
Family medicine.
Yeah, he's family medicine too. Okay.
Mm.
All right. And so when you said you were very interested in surgery at first, was there a moment really when you decided, okay, this is not for me. I want to go family medicine route, or I want to go kind of a non-surgical route.
Yeah, for the time that I was in surgery, I was slowly starting to lose the points that I was initially awarding surgery as my main specialty. And then when I did my family medicine rotation, which happened to be in the community health center of my medical school, I fell in love with the relationships that those doctors had with their patients, that it seemed more real, it seemed
Hmm.
more connected to the human sitting in front of you. There was that continuity aspect where you got to witness your treatments actually making a change in someone's life. There was, shit
Yeah.
talk back and forth between the doctor and the patient in a good way.
Yeah.
Whereas when I was working in surgery or maybe some of the subspecialties, it seemed very transactional and quick and just in and out. Here's what you need to know, and I got to run over to the next patient. And it never seemed fulfilling for me as a person of where I derive happiness and fulfillment from. So I knew that family medicine was for me based off that first rotation.
The shit talking, that must be a New York kind of thing.
Probably, yeah.
I didn't get a lot of that
No?
in Iowa where I was practicing, or
No?
at least in residency. Yeah, Iowa. It's
Yeah,
it's a different type of vibe, I would say,
they
between.
pride themselves on Iowa nice, so that doesn't
Yeah,
Oh,
really.
okay.
but I love that too, being able to have that relationship with a patient to now you probably get more time with your patients than I do, and but the longitudinal aspect of it actually is there's a lot of overlap there between what you get in family medicine and ophthalmology, because we're seeing patients throughout their whole life, and
Yep.
providing their eye care, and it's really great to. And what I tell students and residents is, especially with regard to humor, when you're building a relationship with a patient, even if you only have 5 minutes, if you can share a laugh, if you can have that back and forth where you have the emotional response of laughing at something together, like that just fast tracks your relationship with that patient so much. So even if it's like 5 minutes, you're so connected there, and so humor, shit talking in New York, or dad jokes in Iowa. That's
It's
that's
so
kind of what
true.
it is.
Did you do the thing that most teenagers might do where you say, "Oh, my parents are in family medicine. I'm never don't want anything to do with family medicine," and then you go off and turns out life has a way of kicking you right back into where you said you'd never be?
Yeah, I would. Well, first of all, my dad would try and steer me away from family medicine. He's like,
Oh.
reimbursements
Oh,
aren't
really?
great, and there's a lot of problems here. Maybe this isn't the specialty for you. But I would always be like the nickname Dr. Mike came from when I was a teenager. My friends would come to me with sports injuries, and I would tell them what to do based on what my dad told me to do. So I was already practicing as a family medicine doctor without a license. I probably could have gotten in trouble then. I was like, you got to
uh,
stretch.
right. Well, there's so much there's so much you can offer, from the field that you're in, and I see that in your content. You're addressing. There are so many questions that the general public has about their own bodies, about their own health, and so you're so in such a prime position to be able to offer that advice or information that's a trusted source of information, which is obviously something that the society is struggling with, right? Is finding those trusted voices. And I feel like you certainly provide that, and you're focused a lot of your content on giving people that opportunity to hear from somebody who, you can trust what they're saying. That's why I think, and yeah, I'd love to hear your thoughts on this. Social media is so important for physicians to be really actively involved in, and it's not always easy because there's a lot of difficult things about social media, a lot of negativity, especially toward physicians on social media. So what advice would you give to young physicians who are just starting out on their medical journey in how to approach social media?
I think it's a very messy space, um, especially for medical professionals. Like if you're someone who just makes comedy content and you don't have a medical board watching over you or patients that trust you and respect you, it's a lot different versus when now you're someone who is treated as an expert or carries some level of certification. So you have to be really careful of how you communicate online. Even the line you mentioned earlier with patients in a room and making a joke. And if you can get that joke to land in the first 5 minutes, it instantly improves the doctor patient relationship. At the same time, you say the wrong joke, it doesn't land correctly.
Yes,
No
you're
faster
done.
way to destroy a patient
You're done.
experience. But
Totally agree.
now extrapolate this magnitude to every joke you say now gets seen by 1 million people. And within those 1 million people are individuals who like you, dislike you, don't care about you, share a completely different mindset or life experience than you. So it becomes very difficult
Hmm.
to expect young physicians or anyone in the healthcare space to do well in this space without messing up. Because it's not, nothing about it is human, and you're going to make mistakes. And the analogy that I like to give is almost, to the safest driver. I promise you, if a police officer follows you long enough, you will get a ticket for driving on the line, not turning correctly, not showing the
That's good.
blinker early enough. And on social media, if you're a healthcare professional, you have essentially a squadron of people following
Yes.
you all the time. So you're bound to make a mistake and slip up, even if you're trying your best. So you have to
Hmm.
be aware of that, ready for it, have things in place to adjust and adapt, because it's an unforgiving place. So I give
No,
warning more than I give information when it comes
yes,
to
no,
social media.
I totally understand, what you're saying. It's being able to mitigate those mistakes by,
Mhm.
and as someone who's been through it and is still going through it, and myself as well, trying to show, I try to show the mistakes I've made. It's like, look, I did this, and this was the backlash I got, and you probably shouldn't do what I just did. And so, trying to help, younger physicians learn from experience, because it is not, there's no like formal education in how to be on social media as a physician, but it's so incredibly important because that's where patients are,
Yeah.
right? That's where they
Yes.
are. That's where people are getting their information. And so
Yeah, so if
if
you're not there, it just leaves a void for misinformation.
exactly, yeah. And so it's we all need to be out there in some way. Don't have to be telling jokes or wearing stupid costumes like me, but you could actually be,
No, I think that works
do,
best because that is not, you're not only where people are, aka social media, but you're also there in a way that's relatable and interesting and engaging. Because you could be there and give really dense scientific book information where you're just reading a book, but how many people are going to relate to that? And how well is the algorithm going to reward that content to show it to more people? So it's about being effective just as much as it is actually having a presence there. Even in, I think right before I graduated residency in 2017, I wrote an op ed for the AAFP where I said that the absence of quality evidence based physicians is going to make for a misinformation disaster. And that could not have been more accurate 3 years down the line, because there weren't enough doctors putting out good info. There
yeah.
weren't enough people challenging those thoughts. And as a result, it created chaos. But at the same time,
It's
I understand why doctors don't want to be there. It's so toxic. It's not
yeah.
rewarding at many times. And it's very tricky, as you know.
That's incredible foresight though. Nice job. He is
Yeah. Well, I
fortune
mean, I
teller
think a lot
here.
of people were predicting it, but
Yeah.
I was
Well,
very
still.
passionate about it. So.
Yeah, yeah. Well, let's take a quick break, and then we'll be back with Dr. Mike, and we're gonna play a little game here. All right, so we'll be right back. Kristen, you know that as an ophthalmologist, I don't tend to get excited about
I
stethoscopes.
do know that, yes.
But I have around my neck the Echo Health's 3M Littman Core digital stethoscope. This thing is incredible. It's got active background noise cancellation, up to 40 times amplification.
That's pretty impressive.
I could practically hear the individual myocytes talking to each other.
And I have one too, and mine is rainbow.
Yours is much cooler than
I
mine.
know. I might just wear it around the house with its noise cancellation so I don't have to hear you and the kids.
That's fair. This thing would be perfect gift for anybody in healthcare.
What?
So, we have a special offer for our U.S. audience. Visit echohealth.com/KKH and use code KNOCK50 to experience Echo's digital stethoscope technology. That's EKOhealth/KKH and use KNOCK50 to get $50 off plus a free case plus free engraving with our exclusive offer. All right, we are back with Dr. Mike. And Mike, we're gonna play a little game. It's very simple. This is it's ophthalmology
Is this
trivia.
simple for an
It's
ophthalmologist?
no, no,
An
no.
av-
It's simple for a non-ophthalmologist. So just to make sure we give everyone the right perspective here, uh, non-ophthalmologists get very little formal training or education in ophthalmology. And it's, it is what it is. There's a lot of parts of things in the body that you got to learn. And so, there's only so much time. But eyeballs, as we've already mentioned, is one of the things that kind of falls by the wayside a lot of the times. And
I
so,
got conjunctivitis,
yeah.
corneal abrasions.
Well, you've
I don't
already
even know.
thrown out
Iritis,
preseptal
maybe?
cellulitis. You've already
Yeah.
thrown out preseptal cellulitis. So you're already, better than 99% of non-ophthalmologists, I would say. All right. And so here we go. I have 10 questions for you,
Oh,
and
no. Okay.
it's okay if you don't know the answer. Or this is for
Can I phone
education.
a friend? Can I make a
No,
referral?
you absolutely cannot. There are rules here, Dr. Mike. Okay.
Ophthalmology trivia is very serious.
This is absolutely very serious business. All right. How many eyes does the typical human being have? We're starting off very, very basic. All right.
I'm going
Do
to
you know
go
the answer to that? Very good. I didn't say average person because I guess that would be slightly less than 2. But 2 is how many eyes a typical person has. Name
Oh, yeah. That would
3
have been a
and
good trick question.
it would
Would have
be.
been, yeah.
I was trying to be. I wanted to be nice to you though, okay?
Mhm.
Because this might be a little bit difficult as we get along. So name 3 anatomic structures inside the eye.
Cornea, conjunctiva, sclera.
Good. Those are three structures in the eye. All right, next question. Question number 3. What is an ophthalmologist's greatest fear?
Visine.
Ooh, that's
good.
an excellent answer.
Good answer, but no, the answer is responding to an in-flight medical emergency. That is,
Didn't you say you hate
That-
Visine so much and it's like your biggest fear?
it is. I might have said that. I do hate Visine more than anything else in the world, but I fear it. I don't fear it. We're just
Okay.
mortal enemies. That's all. But
Oh.
that was a really good guess. All right, no, responding to in-flight medical emergencies is the ophthalmologist's greatest
Understandable
fear
why.
in life.
I had to
and
do
that
that
is an
before.
objective answer that is, I think, published in the New England Journal.
Hold on, pause. You had to do that before?
Yeah, I had to save a gentleman's life on a transatlantic flight.
Oh, I did. I read about that. Yeah.
Whoa.
He didn't have an EpiPen and he was going into anaphylaxis, and we had to MacGyver epinephrine from the cardiac epinephrine that we had on board with a needle like this thick.
Oh my God.
And good luck doing epinephrine conversions
Oh,
one
God.
1,000th on a plane with no Wi-Fi.
Oh my God.
So
I
it was
just kind of
messy.
you did it and you hoped for the best. I mean, like that's
Well, he was
that's
dying
incredible.
otherwise, so
Yeah, you had to do
Yeah, you
something,
gotta do
right?
something.
Were you the only person that responded, or did you have help?
there was a plastic surgeon, but there wasn't much utility
Oh,
from that
I would have gone
individual.
with you. Okay.
Yeah.
Yeah, it's a good thing he was there and not you.
Oh yeah,
That guy got lucky.
If you and if I had responded with you, I would have been like I'm here for moral support. All right, you just let me know. Is the patient? Are they wearing contact lenses? I can handle that aspect of.
Pop
Okay.
those out.
All right, let's do it. Next question here. What is the leading cause of blindness worldwide?
I would
Kind
say
of a tough
like
one.
diabetic related
Diabetic retinopathy, maybe. It's a
retinopathy. Yeah.
good guess. It's cataract, actually.
Oh wow.
Cataract.
Well, Mr. Beast just did this. I probably should have known that.
Yeah, I did see that.
What's your take on that? I'm curious.
I mean, I think that it is a huge cause of reversible blindness in the U.S. That's really kind of the sad thing is worldwide, it is a huge cause of blindness, but it's also so treatable. Like the average ophthalmologist does like 500 cataract surgeries every year, and so it is. Everybody gets cataracts eventually, and we need obviously in this country, but worldwide it's a much bigger problem, I would say. So I am, man, anytime ophthalmology is in the news, cataracts, whatever, I'm big fan.
You should do a
So
reaction video to that. That would do really well on YouTube.
yeah, maybe I will.
That's a good idea.
I should. I mean, I got to take advantage of when eyeballs are in the news, right? Whenever
Exactly,
people are talking about it.
So is cataracts the leading cause worldwide and also US? I'm curious.
It is a reversible vision loss.
Got
I
it.
would say it is the leading cause of vision loss, but blindness is kind of a subjective term. So
True.
I would say yes, it is still the leading cause in the U.S., but it's just
Got it.
easier to get it treated in this country than in lots of places.
Got it.
Not medical insurance notwithstanding, obviously.
Facts.
All right, next question. We're going to do a little good or bad. All right, artificial tears, good or bad?
Good.
Just good or bad? Good, good. Visine,
Bad.
bad, very bad. Also, clear eyes is on the Visine spectrum as well. No clear eyes. Sleeping in contacts,
Very bad.
very bad, very bad. Choosing
No oxygen.
ophthalmology as a career,
Amazing.
very
Blessed.
good. It's perhaps the best choice you could possibly make in medicine. I don't know. Family medicine, a close second. I don't know. I just, I'm a little biased. All right, next. What is the name of a disease where high pressure inside the eye results in loss of your visual field?
Glaucoma.
Glaucoma. Very nice. High pressure inside the eye results in loss of your peripheral vision. Glaucoma. All right, we have two questions left.
Cotton wool spots.
Co-
No, sorry.
Oh, yeah,
Was that the next
that was it. You got it. I'm not even going to ask the question. The answer was cotton wool spots. All right. What is an ophthalmologist's second greatest fear?
Having their heart stop in the middle of the night.
He's playing to the to
He's
my
playing to the
to my
yep.
to
mhm.
my emotions
to the
here.
crowd.
It's not a bad guess. No, it actually is relatively close. The answer is hospitals. Hospitals.
Oh, why?
Because we don't like to go there, Dr. Mike.
They don't
Mm.
remember
We
anything
don't.
about it.
The hospital, think about it. It never closes. It's always open, even on the weekend. And as an ophthalmologist,
It conflicts with the lifestyle selection you
it
have made.
does a little bit. And it's I chose outpatient medicine for a reason. So we try very hard not to go there. We'll help, but honestly, we have somewhat limited use in the
You help
hospital
in the
anyway.
way that like a kid helps you bake.
Yeah, I'd say so.
Yeah.
Appreciate the analogy. That's good.
Okay.
Hospitals. All right. And then a patient reports that this is a patient situation here. So
Okay.
let's see. A patient reports that they have been seeing flashes of light and a burst of new floaters. Do you have floaters?
I don't.
Have you ever had any
Should I?
floaters? Little things floating around in your vision?
No.
Do you wear
I have
Maybe when I
glasses
got
tons
or
of
punched in the
floaters.
face while boxing.
Yeah,
I have
you're-
halos.
You have halos. Okay. Maybe a little astigmatism going on. I don't know.
A lot of astigmatism.
Yeah,
My vision's
yeah.
actually terrible. I was going to ask you for some advice on that.
What do you?
He's not wearing the glasses.
You're not
so
wearing
you can't
glasses.
Guess.
So when we have guests that wear glasses, I like to guess their glasses prescription. But
Oh, interesting.
you
I
didn't.
probably should
I
get
should have told you ahead of time.
I don't even know what they are, so I'm bad at that. Again, I don't know what those numbers mean.
You didn't know your own
Refraction.
penicillin allergy.
What is a
so,
refraction?
so flashes of light and a bunch of new floaters. What is one possible diagnosis?
Flashes of light.
What do flashes of light
I
represent?
think I know.
You probably know just because you hear me take phone
I
calls.
know. I think I've known all of these.
Did you really?
You couldn't ask me
That's pretty
something
good.
about like retinal detachment or macular
That's it.
That's
degeneration.
it. Yeah.
You did
Oh,
it.
okay. But what? Don't you have total loss?
No, sometimes retinal detachment can be. You do sometimes have a curtain coming over your vision.
Yeah.
That's like the
That's-
classic thing.
That was my.
But yeah, that was good. Yeah, curtain. But a lot of times people have flashes of light because that's the retina kind of the initial detachment
Okay.
causes these big flashes of light. You got it. Well done.
Look at that.
I
Didn't
think
even
Yeah.
need to use up to date.
no, we didn't. You know more ophthalmology than you give yourself credit for. So
I think
you
it's
knew
because sometimes on YouTube videos I have to look stuff up about it.
that's something.
That's the only reason he knows anything too.
Yeah, I
No,
and
that's scary.
Oh, it's actually whenever because when I'm playing these different characters and different specialties, like I don't know anything about
Yeah, not
cardiologists.
ophthalmology. He's very smart ophthalmologist. Outside of that,
Oh yeah,
it's
when I
on
get outside,
YouTube all the
that's
way.
what I'm talking about. Like neurology, nephrology. I don't. The further I get from med school, the less I know, and so I have to actually do a lot of research. So I'm actually maybe a little bit smarter about like systemic medicine than I
You
used
might
to be.
be.
I don't
See,
know.
social media makes you a better
It-
doctor.
It works. Well, that was ophthalmology trivia. Thank you for.
I have a
for
very pressing
obliging me.
question, though.
Oh yeah. let's
Oh.
do it.
I want to know, Dr. Mike, what do you think of his family medicine character?
Oh, I love it. It's me. Had I not had social media. Because I'm very lucky in that I pretty much work for free as a family medicine doctor because of how lucky I am with social media. But had I not been able to dictate, I want longer with this patient because again, I'm here for free. So I want longer to be able to help the patient.
Mhm.
I would have to be seeing a new patient for anxiety, depression in 15 minutes, where 5 minutes are reserved for vitals. Now I have 10 minutes to find out who they are, what's going on in their life, create some sort of meaningful relationship, give optimal treatment options, describe the options, have some sort of
Yeah,
rapport to see if they understand it. And it's a disaster
it's
of a healthcare
impossible.
system. So I love your family medicine. I
Oh,
actually just I
I
remember
appreciate that.
you were getting some nonsense on social media about that, and I remember tweeting and being like, "That's ridiculous," because
Yeah,
we have
yeah,
to
it's
speak out against that.
that's the one character that I, people
It's a little divisive.
that's a little bit, it's the most divisive character, I would say. And I think, and I've listened to all the feedback, and I think in the end I try to portray family medicine as a little bit of a sympathetic figure just because of how overworked and underappreciated you are. And I think it's just that field, primary care, is taken advantage of in a lot of ways in our medical system. And so I think the reason for some of a little bit of the backlash is just because like they see someone that's kind of making fun of family medicine, but not really. And I think it strikes some people the wrong way. And I
The
get
way
it.
that
It's,
the way that I see it is they have absolute reason to be hurt because that's the field that's kind of lost its way and hasn't been rewarded in terms of celebration, at least based on the specialty.
yeah.
So they're hurt, but they're displacing their anger at what's going on with the field at you, who is not the person that is deserving of the anger.
Oh, well, I appreciate that. And I personally really like that character. It's one of my favorites. So,
Me too.
all right. Well, let's, do you have any, well, actually, we're going to go into some fan stories real quick.
Yeah, some
Oh,
So,
listener
exciting.
submission.
yeah, we'll be right. We have two fan stories. So we'll be right back with those. All right, let's get it. We're keeping Dr. Mike on with us for this listener mailbag, and that was actually a suggestion from Josh Andrews 6839 for suggesting that, so that you can react to it with us about these. And so we have two stories. The first one comes from Efrat, and this is just kind of a sweet. This is a nice little thing here that really gets to caring for older adults. So he says, Efrat says, I'm a medical intern doing a rotation in family medicine. Today, I took a very sweet 92-year-old's history. While doing a physical, he mentioned that I'll probably hear his heart murmur. With no history of a cardiac disease, I asked him if he ever looked into the murmur and if he knew the cause of it. He responded with, I did some tests and everything looked fine. I guess it's because I met my wife 50 plus years ago and fell so hard in love that I've had a heart murmur ever since.
Aw,
Aw.
When I finished the H&P, he told me, thanks, Efrat. I'm very proud of you.
that's so
Do you know
That
where my
cute.
dark comedic mind goes with that?
Where? I love
That
dark
his
comedic
wife,
minds, so please tell me.
okay, that his wife stressed him out so much he became an IV drug user, got bacterial endocarditis, and then developed a heart murmur. But
That
that's my
escalated
comedic mind.
quickly.
That's not what
That
actually happened.
Mike, that was the rest of the story. You
No,
gotta let me finish these things.
he has
What?
excellent foresight.
Wow. You're like a fortune teller today. My goodness. But if that doesn't like tell you that you gotta work with this patient population, that's why I love older adults so much.
Yes.
They just will pull stuff like that out of their hat. Okay. Fan, and there was no endocarditis associated with it, which is great. All right.
Amazing.
Second story comes from Cassidy. So Cassidy worked as an MA in her dad's surgical office and clinical office to build up some experience before starting PA school. And she was taking out a patient's stitches after a laparoscopic cholecystectomy. And her dad had already explained to the patient that he had to lay low for a couple of weeks to let the abdominal muscles heal, no heavy lifting, no strenuous exercise, all that stuff. Well, this patient was apparently too embarrassed to ask my dad, a very serious surgeon with very little time, a pressing question. So he asked me, the MA, and his daughter, of about the same age. I'm getting married soon, and do you know when my fiance and I will be able to have sex again? I had never had anybody ask me that before, so I said I'd ask. and I had to ask my dad for the patient. And he said, I don't care what he does as long as he doesn't pull his stitches free. Tell him if it hurts, he needs to stop. That's, it's funny. And when I read that story initially, it brought me back to the one time I actually had a patient ask me after cataract surgery. There's one time if it was okay to have sex after cataract surgery. And that was as close to a sexual history I think I've had in quite a while. So
what was your advice?
I said you can't lift anything more than 30 pounds. Which is that's just my standard like post-op instructions, and I let the patient just
Extrapolate.
decide what that meant for them.
Okay.
Yeah.
I could
yeah.
see why you went in that direction.
Yeah, you probably have a lot more sensitive conversations around sex than I do in my line of work, I'd imagine.
For sure. And also, I unfortunately have to do a lot of pre-surgical, preoperative clearances for cataract surgery. And for some
Ooh, I'm
reason,
sorry about
all of
that.
these ophthalmology practices require EKGs and all of these things that are not mandatory.
I was
It's very
really
frustrating.
hoping you weren't going to bring that up because it is a
Sorry.
bit embarrassing for ophthalm. No, it's okay. Now I will say, like, I never send people for EKGs. I wish that would go away. Now I do send people for cardiac clearance, and the argument you'll get. And
Okay.
by the way, one thing
Is that
I
because
learned
you
from
use lidocaine and you're worried about arrhythmias or something?
it's well, listen, our surgeries, our minimally invasive surgeries last almost 6 minutes. All right. How am I supposed to know if a patient can tolerate minimal sedation with that? It's 5 milligrams of Versed. It's not 5, 1 milligram. But anyway,
I was gonna say you're putting people to sleep.
yeah, we don't want that. We don't want that. But one thing I changed in my practice with social media is I stopped saying cardiac clearance and I started saying a preoperative risk assessment.
Okay.
Which I guess just
Can I
the
give you even a
wording.
better one?
What's that? Oh, please.
Pre-surgical optimization.
That's good.
Because
That
that's
is
what these
good.
are.
That's good.
It's-
Yeah.
I can't prevent the patient from having risk, but I can lower their risk by optimizing them for the surgery.
I love it. And
Got a nice positive spin on it too.
yeah, and
Yeah.
everybody, if you're an ophthalmologist listening to this, stop ordering the pre-op EKGs. Or what good is that going to do? We don't need that. All right. Well, thank you to Efrat and Cassidy for your stories. You can send us yours, knockknockhi@human-content.com. Dr. Mike, thank you so much for being here. And so before we go, I want to say, thank you for the advocacy again that you've done around chest compressions. As someone who has been saved by chest compressions, that's a big deal. And we need more physicians talking about it because there are very few interventions that have the kind of success that anybody can do. And it's such a valuable thing. So thank you for focusing on that.
And I would just add my 2 cents that I've always got to add when we're talking about chest compressions, which is, don't forget about the people that do the chest compressions, because often those are not trained medical professionals. Those are just everyday people, and often they're doing it on their loved ones. It's a very, very traumatic experience, and you see and hear and feel things that you are not prepared to. And right now, there's just not a lot of support out there for those people that do that. So don't forget about those people and providing the support that they need as well.
You're absolutely right.
So tell us, what do you have coming up? What do you want people to know about?
Check out my podcast where we interview interesting folks from non-health space. We have athletes, politicians, actors, comedians, really exciting conversations about not just physical health, but mental health as well. So I'm really excited about the podcast called The Checkup with
Awesome.
myself.
I've seen some clips of it on social media. I saw the clip you did. You posted one recently with oh my gosh, the name's blanking.
Tony Hale.
Tony Hale. Yes.
Tony
yes.
Hale.
See, we
That
can
was
read minds.
amazing. That was awesome. Nice job.
Yeah, he's awesome and such an empathetic soul. So it was great sharing that story with
Yeah.
him.
It was a good conversation.
About
So,
chest
yeah,
compressions when
That's
sometimes you
right.
should stop chest compressions. So
Yeah, yeah, important stuff. And then, if you look hard enough, you can find Dr. Mike on social media.
You might really have to
It's a
dig.
little bit tough. He's out there in the corner of the internet. So check him out you're on YouTube. You're pretty much everywhere, right? Instagram, YouTube, Twitter. Well, thanks again for your time. It was a pleasure
Thank you.
talking to you.
Thank
Appreciate
you.
you guys.
Well, that was great talking to Dr. Mike. That was
Yeah.
good.
Yeah.
He's got such a big following, and I like what he's doing, with education in particular.
Yeah. It's so important.
Yeah, especially to a non-medical, audience. And
And
so,
like you said, it's not always easy to do. You get a lot of pushback and a lot of criticism, and the internet is not a very friendly place sometimes. So
You
kudos
do.
to him for sticking it out and doing that.
yes, you got to have a thick skin, and especially, I mean, his platform, he's got 10 million subscribers on YouTube, and so I can imagine there's a lot of stuff that he has to deal with with that, and so but anyway, yeah, that was awesome. Good
Yeah.
talking with him. Thank you for the stories also, and if you have your own stories to share, we would love to hear them. Have you thoughts about our conversations with Dr. Mike or other guests? What'd you think about ophthalmology trivia? Do you want me to subject more guests to answering questions about eyeballs? Because I would love it. Please tell me to do more of that. There are many ways to hit us up. You can email us, knockknocki@human-content.com. Visit us on TikTok, YouTube, Twitter. We have, you can hang out with us in our human podcast, I always said human content podcast family on Instagram and TikTok @Human Content Pods. Thank you to all the great listeners leaving wonderful feedback and reviews. If you subscribe and comment on your favorite podcasting app or on YouTube, we can give you a shout out. So we had Nuts About Medicine. Great name. Nuts About Medicine on Apple said, thank you for humanizing what has become a non-humanizing field of healthcare, of our healthcare system. And thank you for getting the most depressing field of medicine out of the way on your first podcast. That
He
being
might be
said,
referring to the oncology podcast
referring
with
to
Dr. Dizon.
Dr. Dizon and the oncologist. That being said, having lost both parents to cancer, we need more Dr. Dizons, and I could not
Absolutely.
agree more. Yes, sometimes where it will be sillier on this podcast, sometimes it'll be a little bit more serious. I like to give you, because that's what medicine is.
Yeah,
honestly,
that's what life is.
That's what everything is. A little bit of serious, a little bit of fun. All right, and full episodes of this podcast are on YouTube every week at my YouTube channel at Glaucomfleckens. Also, join our Patreon. Tons of cool perks, bonus episodes where we react to medical shows and movies. You can hang out with members of the Knock Knock High community. We're active in it. I posted a video answering some questions last week. It was great, and I love interacting with everybody over there. Early ad-free episode access, interactive Q&A live stream events, much more coming as well. Patreon.com/Glaucomflecken or go to Glaucomflecken.com. Speaking of Patreon community perks, we have new members, Derek N. Rausex something. I'm sorry if I mispronounced these. Their handles. I'm not sure. I do my best. Amy and Shannon. Also, shout out to the Jonathans. We have a pack of Jonathans now. Patrick, Lucia C, Sharon S, Omar, Edward K, Abby H, Stephen G, Roskbox, Jonathan F, Marion W, Mr. Granddaddy, Caitlin C, Brianna L, and Becky.
I love that we have a Jonathan named Jonathan.
That's true, we do. Jonathan named Jonathan. It's a little bit meta. All right, now for Patreon Roulette. This is, for people who sign up as an emergency physician on our Patreon. We will shout you out a random member of that tier. So, Patreon Roulette. Here we go. Oh, that's my drum roll.
Yeah.
Is that pretty good?
That's pretty
I
good.
think.
That's pretty good.
Shout out to Human Y. Human Y. I hope I'm saying that correctly. Human Y for being a Patreon. We appreciate you. Hope you're having a great day. Next, we have Diagnosis Improv. So this is a new thing we're doing. If you're on Patreon, I think it's the pediatrician. If you are a pediatrician on our Patreon, and you can send us a word, a made-up word, any word you want that's safe for work, And we will read that word and try to come up with a diagnosis
Ooh.
or a definition, or just basically what is that word you just gave to us. And so we have one today from Omar. He gave us the word proctonostrum. Proctonostrum.
Okay.
That does sound like a medical term.
It does.
What do you think it
I
is?
think it would be when your butt grows a nose. It's a condition
That's
in which
good.
you have a butt nose.
Oh, that would is it a functional nose?
Well,
Or is
I
it- or
don't
is
think
it
you
like
want a
like a
nose
tumor?
on your butt, so I don't know. It doesn't seem good. I don't think
Butt-
it's desirable.
A nose on your butt. Oh man, what a bad place to
It
have.
would be bad.
I-
It would be unfortunate.
I like yours better. I was gonna go with proctonostrum being that that everything you smell
Smells like butt?
smells like butt. Like that, like somehow all the neurons that go from your olfactory, system
Are
to your brain
connected to
somehow get rewired into butt smell.
Yeah, that also would be unfortunate.
Neither
Related
of them are
conditions.
good. Proctonostrum. There you go. Thank you, Omar, for that. Thank you all for listening. We are your hosts, Will and Kristen Flannery, also known as the Glaucomfleckens. Special thanks to our guest today, Dr. Mike Varshavsky. Our executive producers are Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, Shanti Brook. Our editor and engineer is Jason Portizo. Our music is by Omar Benzvi. To learn about our Knock Knock Highs program, I said that like I was singing it. Knock Knock Highs, because I like the intro so
It's
much.
a good.
I sometimes
It's a
sing
good
it on
intro.
to learn about our program disclaimer and ethics policy, submission verification, licensing terms, and HIPAA release terms, you can go to glaucomflecken.com or reach out to us, knockknockhigh@human-content.com with any questions, concerns, or jokes. You can send us jokes.
Mhm.
I always love a good joke. Knock Knock High is a human content production.
Knock knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.